Hello, everyone, and thank you for joining us today for the webinar on treatment of cobalamin metabolic disorders through subcutaneous catheter. Our featured guest today is Dr. Andrea Bordugo. He is the head of the Inherited Metabolic Diseases Unit, Department of Pediatrics at the University of Verona, Italy. He is the clinical chief of regional for the Center of Screening, Diagnosis, and Treatment of Inherited Metabolic Disorders and a member of SSIEM and SIMMESN. He's part of their coordinating the working group on dietetics and metabolic disorders. His clinic published their findings in the report Vitamin B12 Administration by Subcutaneous Catheter in a Cobalamin A patient in 2017 through the Journal of Inherited Metabolic Disorders. They have since expanded upon this work with other cobalamin patients. We are thankful to have Dr. Bordugo with us today. All right.
Okay, thank you very much, Dani, for the kind introduction. It's really a pleasure to me. Hello, everybody. I know that there are many people connected from all around the world. And I actually, as Dana told you, work in Italy. You can see in my first slide on the top right, the arena of Verona, which is an ancient Roman buildings and in this beautiful town northeast of Italy. Actually, I'm honored to head a team who's especially involved in newborn screening. And you know that newborn screening is a powerful instrumental thing that allow us to diagnose early neonates, and so we can do to these neonates and start early treatment and make their lives better. I must thank Rossella Brindisi from Cobalamin C Association in Italy, because she at first contacted me and she made this possible, this connection with Dana in the United States. And my topic today is very specific, and I want just to share with you a few slides. I know I'm a medical doctor and you are parents and patients, but I think we must share something together, which is this makes our power much stronger, because it's very important that we work together. So I want just to be clear some essential clinical things to you, and maybe you know already. I think that sometimes my patients are better than me. Sometimes they do suggesting to me, they surprise me. So I hope tonight, because here is 5 p.m., so it's dark, and maybe in other places the sun is still rising. I hope this section will be very interactive. So please, at the end of my topic, feel free to make questions. So this is my declaration that I do not have any major conflict of interest related to the issue I will talk about you today. Cobalamin. Cobalamin for you is everything, and for parents and patients is vital. And we know that it's vital because something is not working in a metabolic pathway producing the active form of cobalamin. And cobalamin has a special role for transforming, for example, a very important acid, which is called methylmalonic acid. I know you're very familiar with this acid. And it is very important to transform methylmalonic acid to succinic acid. And then another important role is to transform homocysteine to methionine. And at the end, it's very important for the DNA synthesis. So just with this slide, you can understand why it's so important that the pathway of cobalamin synthesis work well. And this is a picture that show all the pathways that go through and at the end explain the important actions of cobalamin. As you can see, the two arrows, red arrows, as I told you before, there are two very important steps. One is the transformation of methylmalonic acid to succinylcholine acid, and on the bottom arrow you can see where it's very important cobalamin is to transform homocysteine in methionine. It's easy to understand that if cobalamin is not synthesized well, you have a block of these two pathways. So you have an increased amount of methylmalonic acid and homocysteine with all the clinical picture, you know. Now, as I work in Italy, and so I work in the European Union, I just want to share you an example of how people can join together their experiences. And this is a very important paper. First author was is Martina Hümer from Switzerland, and she make important experts on the field of cobalamin to join together their experiences, and they published this very important paper in the Journal of Metabolic Diseases in 2017. And I think this is the list and the most updated guidelines for diagnosis and management of cobalamin-related remethylation disorders. So you can see all the list of the diseases. I don't want to go in details, but we know there are many diseases. This is the most important point. We know that cobalamin C deficiency is a very, very important disorder, not very easily treatable. We have now this important thing with newborn screening that make us work in time. It helps us to act early and quickly. But we know that even if we act early and quickly, sometimes is not very powerful, the treatment, because anyway, some children experience developmental delay or eye problem. But this is at the moment what we can do at our best. So I won't concentrate, as our topic is the use of hydroxycobalamin, and want to just to point you this part of these guidelines of Martina Hümer. And if you know in this part what they say, hydroxycobalamin is very important. And we must use hydroxycobalamin as a treatment, which is much better than cyanocobalamin, because you know the market has very different kinds of cobalamin, so we must be very careful. And the vitamin, which is let's say physiological working and in a proper way, much better than the others, is hydroxycobalamin. And why? Because hydroxycobalamin has a much more, we call affinity. So it works much better, and it does much better its work as coenzyme in the molecule what it needs to be treated. We need to work in the two pathways I showed you before, metabolizing methylmalonic acid and homocysteine. Going through the parental route, especially for cobalamin C, is very important to use the parental route. What does this mean? This means that we can use IV, subcutaneous, or intramuscular. Some people have even used oral, but we know that this is not our case. In cobalamin C, we must use parenteral, so we cannot use the oral way. we know, and you know as parents, that every day you must do and perform the injection of cobalamin that IM is painful, gives a lot of discomfort. We can use IV, but this we can use in, I must say, emergency, because it's not practical. It's not life to use IV. It's too difficult to practice and to use an IV route for a daily administration. And I think that subcutaneous is very attractive. Even if there's no enough data, I think this way must be more analyzed, because can offer us, I think, a great way to reduce the discomfort of our children. As you can see, recommendation 21, all the experts are telling us it's very important to use parenteral hydroxycobalamin. And again, we cannot use the oral. In other cobalamin disorders, we can try to use oral, but not this case, not cobalamin C. Now, another important thing, just give you a picture of what experts or clinicians are doing around Europe. And as you can see, the title of the article is again on Journal of Inherited Metabolic Disorders, which is our, let's say, Bible on metabolic disorders. They put all together a great number of experts and centers dealing with these kind of diseases. And they published this paper, Phenotype, Treatment, Practice, and Outcome in Cobalamin-Dependent Remethylation Disorders and MTHFR Deficiency. And this is each EHD Registry, which is a European registry. I think maybe is even accepting people from non-European countries, but it's a very important because it teaches us that we must put together experiences, because, you know, rare diseases are too rare to be treated just by single centers. We must put together our experiences. Otherwise, we cannot go forward. We cannot give our patients new things, and especially scientific proofs that what they are doing is the best way to do. And in fact, if you see in the top right square, you can see that, for example, in cobalamin C, surprisingly, only 70% of patients receive both hydroxycobalamin and betaine. And you know that betaine is very, very important in this kind of disease because lowers homocysteine and increase methionine. But the most important thing is that we know we must use together to pull down homocysteine, because homocysteine is very difficult to lower. But surprisingly, these people asked to the center what they are doing actually just a few years ago, and you can see that they are using only 70% of people is receiving both medication. It is very surprising. So about 20% use hydroxycobalamin or betaine. So what these declarations say that we think that people do the same things in all the world, all around the world, but it's not the truth. So even maybe centers that are close one to each other, even in, for example, in Italy, North or South Italy, you discover that the patients are receiving different kind of treatment. And this, I think, they create sometimes fear in parents, because, for example, your association, you be in touch, you share experience, and you hear that people from different countries do different things. And so I think for a parent, it's very distressing because maybe they are asking, am I doing the right thing? So this kind of paper is very important because show us that we must do in a different way our practices. And for example, now in Europe, recently has been created the Metabolic, which is a network of experts in rare diseases that collect all major centers in Europe, and is starting to collect in a registry, a huge registry, to put together experiences and to learn how work better for these kind of diseases, especially in this case for cobalamin C or methylation disorders. Now, going back to subcutaneous and intramuscular route, which is, I think, the main topic of my talk today. As you can see, we can deliver medication in different ways. Our dream would be oral, but we know we cannot use oral in cobalamin C. And so I want to go through with this kind of way, which is different and maybe less painful and traumatic for children suffering from cobalamin C, which is the subcutaneous route. Now, this slide show you two different way of administration of hydroxycobalamin. They are called ports, and are small needles that go inside the skin. I think the major experience in this field has been from diabetic people, from diabetes. And all these kind of ports have been created with the aim to reduce the stress of daily injection and reduce the stress, even especially, I must say, for small children, because, you know, small diabetic children, they must receive 2, 3, 4 times a day insulin. And imagine how stressful can be to receive these so many times each day of your life. So people came out with this possible solution, which is a tiny plastic catheter that you can insert just once every 5-7 days. It depends on the kind of port. These are the two, I think, most known kind. One is the insufflon, and the other is the iPort. Slight differences, I must say. Insufflon is a bit less expensive. I know that, Dana, I allow you to use my slides and the registration, so people can just go and see again. Here are all the prices. I don't want to go through all these kind of economical aspects, but they are very important anyway. So you can see insufflon you need an operator that help you to insert the needle. So there is a needle, and you can see on the left, on the insufflon, you can see the hand of a operator that insert the needle and then take out the metallic inside and leave just the plastic one. The iPort, which seems to us more attractive, has this kind of characteristic, and then I show in the video at the end of my presentation, is just straightforward, because you will see the father doing her child is easier, because you just insert, and then you give like a pressure, and then the needle go inside. So is quicker. It is much easier. That's why we thought, looking at the experience of our colleagues from the diabetic clinic in children, why don't we use this kind of iPort for our children with cobalamin deficiency that needs a parenteral route of administration, because we didn't want to use IM. We didn't want try to use intramuscular, because we know that it's very painful. And I think even for parents to give a shot every day in the muscle that their babies is very distressing. So we wanted to try this way. There was some literature, so there were other papers in the literature telling us that in cobalamin C we could use safely subcutaneous administration, and not only safely but even in an efficacious way, so that it was working like the IM way. And this is what I'm talking of. You know, this is the iPort is the company is the Medtronic, which is a very well-known medical company, which is doing a lot of things in the medical field. But this is what we concentrated on, which is the iPort catheter. And I will show you in details at the end in the video. But as you can see, you can insert in the skin. You can even easily insert by yourself, so you don't need help for others. You can do what you need by yourself. And then you see this lady injecting what you need to do. And we wanted to use and give cobalamin. Now we know that different centers use different dose, and in our European countries, usually we start with 1 milligram. So when a diagnosis has been made of cobalamin C, the recommended dose is 1 milligrams each day, intramuscular injections. And so we try and started the subcutaneous way. And we know that we can go up with the dose. And for example, in one patient, we use hydroxycobalamin 5 milligrams twice a day. So we can go up to 10 milligrams, which is, I think, a good amount. There are other centers using sometimes with it's called mega doses, so much higher, even 20 milligrams. You know, subcutaneous device, usually we cannot go up to more than 2 ml, no more than 2 milliliters, because otherwise it's too difficult to go with a syringe and give bigger amount in the subcutaneous space. So this is a little negative thing. But in our children, we think that 10 milligrams is anyway a very good dose to go on. And another important thing, we ask to our children to rate the pain, and this is what usually say, and you will see, in fact, in a little baby, in a little lady in the video, gives just a mild discomfort. Is the score from 0 to 10, usually they just give 0 or maximum 1 to 3. So it is not painful. And if you think that once you have inserted, you can leave there, so you have no more injection to do, you just use every day. What you have to do is to change at least 1 in 5 days. We push forward even 1 to 7 days. The important thing, if you must be careful how it's working. So you must look around the skin, if the baby is in discomfort, redness around the skin, but we use safely even 5-7 days. So it's more than what the manufacturer declared, because usually they recommend you to change every 3-4 days, but we put forward this limit. Now, these are our patients. We have tried in these two patients, are completely different patients, even if they have the same mutation. As you can see, patient one is a small baby we diagnosed with a newborn screening. And you can see on the details, MMA, which is methylmalonic acid, which is 93, normally is below 5 in newborn screening. Homocysteine was 57, normally is below 10. And so we have a powerful instrumentation that make us to start early. And so, in fact, we started early to give 5 milligrams a day, which is a 2 ml volume, IM, but then we put the iPort and we carry on with the subcutaneous administration plus betaine. So this is a recommendation that all people with this kind of disease should use homocysteine, hydroxycobalamin plus betaine. And now this patient is improving well, and the neurological development and the eyes and the heart are perfect. So we hope we will keep doing well with these babies, and his homocysteine level and methylmalonic acid level are completely normal. Okay. Patient 2 is a really a strange history, because she was a perfectly well baby, growing well, then a girl going to school. Suddenly, at 12 years of age, she started to have a dramatic picture of suffering of the brain and even of the brainstem, and she cannot walk anyway. Luckily, one of my colleagues asked to dose homocysteine, and again you can see the level was 212 and normal is below 10, so a huge increase in homocysteine. And we started her in with 5 milligrams, and now she do herself insert the iPort, and she do everything by herself, 5 milligrams in the morning and 5 milligrams in the evening, plus betaine. Normal achievement of methylmalonic acid and homocysteine. I must say, now she didn't recover. She had major problems in walking, but she's improving. And so we know that we can try and give her all our support to improve in the future. But she is a lady and a girl that need a lot of support. But this is the picture of cobalamin C. You know, sometimes the treatment are not so effective on changing the clinical picture. And this is a family. It is an amazing family with 3 babies, all with a cobalamin A deficiency. You know, cobalamin A deficiency is a different deficiency from cobalamin C. You don't have homocysteine homocysteine is normal. So you only have methylmalonic acid, which is very dangerous, because you see the first of all these 3 children, he now is 5 years old, started with a picture of metabolic acidosis and vomiting. Luckily, she was in the hospital near our center, and we had a quick report from newborn screening when we started early with all the treatments, and especially hydroxycobalamin. So now this child and the 2 other daughters and sister are perfectly well, just with the iPort administration of hydroxycobalamin 5 milligrams a day. So every day the parents give 5 milligrams of hydroxycobalamin using the iPort. And so the older patient, 5 years old, is the one that we published, and Anne told you before in my presentation, presenting me, this is the patient we published in Journal of Inherited Metabolic Disorders. And hopefully we will collect all these patients and publish in with other centers in Italy. This is very important experience. Why is important this experience? Because, for example, in Cobalamin, a patient, we avoided intramuscular hydroxycobalamin, and we have quite a normal methylmalonic acid levels, slightly above the normal normal levels. But the most important thing is that these children can eat just a normal diet. You know that in this disease, methylmalonic acid is related to valence, to some kind of amino acids. So some children must be treated with a low protein diet. And this is fantastic thing that they can eat mostly all things and just performing the high-port injection every day of 5 milligrams of hydroxycobalamin. I think this is a very important clue to go with this kind of way of treatment. So this is a picture that I showed even in Rome Cobalamin C families meeting, which was almost 2 or 3 years ago, but these remarks remain the same. So in Cobalamin responsive patients, subcutaneous administration maintain a good biochemical profile. And there are, as I told you, Van Hove, which is a great metabolic experts working in the United States, Frischoff in 2011, and Dr. Meines, at the time she worked with my team and published this paper in Journal of Metabolic Disorders. We think that subcutaneous way is a way which could be effective and much less invasive, so must be considered for our patient with cobalamin C deficiency. So we published in cobalamin A patients, but we think that it's time to try to promote studies with great numbers of patients that use this kind of high-port even for cobalamin C, which we believe that it works, and it makes life of this patient much easier. So at the bottom you can say, to be confirmed on a greater number of patients and more severe phenotypes needing higher amounts. So what I must say is that this is a great way to give hydroxycobalamin, but we are scientists and we must do what we call powerful studies. So we need more patients. We need to understand better and to be in the safe side. I think that this is very important, even from the association point of view, because you have the power. I mean, in Italy, this is what happening, that patients are asking doctors to change the way of cooperate, work together, share experiences. And the registries that are now are beginning, as I showed you, the Metaburn and the EHD Registry are in the way to show that is a new way to treat such rare diseases. This is the publication. I think you can easily access and read. As I told you before, is for cobalamin A and not cobalamin C, but we are actually using even in cobalamin C patient, as I show you. And this is all my team working together, even involving not only from Verona University, but even Padova, which is in the same Veneto region. And but you can see even from Zurich, where Martina Humer works, And so I think metabolic cannot be performed just by one center, but many centers that work together. And this is part of my team. And I want just to say thank you very much for your attention. And now hopefully I will be able to show the video. I think this is very important thing. Thank you very much. Okay, Donna, let me see.
And after Dr. Bordugo shares the video, we'll address the questions that we have in the Q&A.
Can you see the video?
I don't see it. We see your PowerPoint. Maybe stop the share screen and then.
Yeah, I'll try as before. Okay.
Yeah.
Now?
Yep.
Okay, is it the father? I just go back. Sorry, just when let's okay.
Wonderful. That's really impressive how still she sat the entire time, even with the phone. I'm very impressed. Do you have anything to add before we move into the Q&A section?
Just as I told you that I think just looking at what a father does every day just help to understand how things can be much easier. I just think into the parents that must cope with the stress of doing intramuscular injection. And I think this can even act negatively in the compliance with the treatment. I think around the world, a lot of parents cannot cope with a daily injection to their children. I think it's very difficult to inject your son every day with such a painful injection. So iPort, I think, could be a great way of using and performing treatment. So that's, for me, is very important to share the experience.
Yeah, we really appreciate it. And I think every parent here would agree with you. So we have a couple of questions here. And there's a couple of them that are alike. So one of the questions is there a maximum amount of medication that can be put through the port at one time? And the other person's comment just was confirming with the port, the maximum volume is 2 shots a day of 2 ml each. Is that correct? So I guess how much can be put through it have they tested higher doses throughout the day to see our concentrations?
Can I answer to
Yeah.
Brittany? Okay.
Yeah.
Thanks a lot. So this is a great question. I think I do not actually have the answer. I mean, I think it depends on what every country has can use and which are the products that maybe are available in the United States or in Italy. I know that parents even sometimes they are, as they do IM, they are looking for very concentrated ampoules with. So they avoid to do maybe every day, and they do alternate days or every 2 or 3 days. But to answer to Brittany part this question, as I showed you, we and what the literature said that 2 or 3 milliliter amount each time is the maximum. Otherwise, what you see is like kind of swelling, you know, it forms like a blister, and it's difficult then to be reabsorbed. So it's too risky. So I wouldn't go more than 2 or at least 3 ml. In Italy, there is this hydroxycobalamin ampoule of 2 ml, and inside need to be prepared because there is a powder and an ampoule of sterile solution that you mix together, and you have a 2 ml with 5 milligrams of hydroxycobalamin. And as I showed you in the girl, we use twice, so we give 5 plus 5, but you can maybe even use 5, 5, and 5, so reach up to 15 milligrams. So I think is a good amount you can achieve.
Mm-hmm.
And okay, did I answer well to the question? I hope yes.
Yes, I think that answered that. And then her next question was, did you, you know, I'm going to skip around in her questions just a little bit here. She said, did the patients you treat experience discomfort from the actual medication rather than just the injection method?
You maybe so you mean that if the medication per se is painful. So when we is gets slowly inside, make it painful as a medication. This is the question thing.
Yes.
The little baby showed us, she keeps doing her things while the father was flashing with the medication, and so I think for what concern subcutaneous is not a painful way, even on looking at the medication. I'm not sure if you give an IM, this cobalamin could be painful per se. I mean, just looking at the cobalamin, what I've seen is that even if you do IM, usually children are in pain when you give the shot and not when you go, like, for example, if you use penicillin intramuscular, this is very painful even when you push slowly in the muscle. But it's not the case for cobalamin IM. I think for cobalamin IM is what is painful. The painful experience is just the needle that go inside the muscle of the baby.
Okay, I think that makes sense. And then, did you see improvement in homocysteine levels when the hydroxycobalamin was given twice a day instead of just once? So does the body do a better job absorbing it and using the hydroxycobalamin if it's spread out versus given at one time?
This is, I think, a really great questions. And again, I must honestly say I've not have the answer because we are not using just hydroxycobalamin for treatment, but we use like betaine. And I think that betaine, without betaine, homocysteine, I think will stay high. Maybe for hydroxycobalamin is better in lowering MMA, methylmalonic acid, but without betaine will be in trouble in cobalamin C to lower homocysteine. To answer to Brittany part, the only way to answer this is to construct studies with more people, and so putting together even adult patients or children and see how is the way of acting of and the way of lowering of hydroxycobalamin giving just once or twice a day. I think would not be easy to prove that, because we are not using just one medication for cobalamin C, especially for cobalamin C we are using hydroxy plus betaine.
Mm-hmm. That makes sense. And I guess that leads very well into Aaron's question here. It says, is it helpful for patients outside of the US to try to join the EHD, and how would we do that? I believe there are at least 2 US sites that are part of the EHD Consortium. Maybe there's another one I'm not aware of. But would that be helpful to have patients, the US is a very large country. So would it be very helpful to talk to clinics and seeing about joining the EHD Consortium?
I would answer yes, will be very helpful, because more patient we have, clear we can understand how things are doing for these specific kind of diseases. So my recommendation is to ask to the doctors who are in charge of your cases to be in touch with the metabolic units of a reference center in the United States, and try the way to make connections, and because this is the only way to give answers for such rare diseases.
Mm-hmm. Yeah, and so if anyone is wondering, they have a very wonderful website with all the papers they have published, the guidelines, and some resources for parents. So that website is e-hod.org. So e-hod.org. And you could share that website with your clinic, and there's a drop-down tab for healthcare professionals, and then they could contact them. Or I'm sure if we put them in touch with Dr. Bordugo, he would be glad to also make the proper connections within the EHD Consortium. But I do think that, the more patients enrolled in such a registry, the more powerful the numbers, and that's when we really get data that's useful to research and to patients, and helping drive these rare diseases forward. The last one I think was a good question, and I think it was alluded to in one of the pictures. And I probably should have asked this earlier along the lines, but it says, can the port be put on different areas of the body? What areas work the best for young children? I know I have a 3-year-old daughter, and if it's on her arm, that would probably just, like, I'm thinking about it catching on clothes. Are there other areas that you have found that work well on the body for patients, or are there limitations to where it can be put?
Again, Dana, there is not such experience to tell us which part of the body is better. But what we use is the one you showed us, is in the upper part of the arm, or even we use in the legs, in the upper part of the legs, or for some children that tend to take it out, we put on the back, because sometimes we have children that tend to take the eye port and take it out. And so parents found this way to put on the back, and it actually did work. And so sometimes we use it in the back part of the body, but there's no any kind of scientific publication that can tell us which part is better.
Okay, so it's probably anywhere that you could do a subcutaneous injection, you could attach the port, correct?
Yeah.
Okay. And I think we've answered all the questions. Aaron's question, I think, was answered earlier about the maximum volume. And so all that we have left is a thank you. And we are so appreciative of your time this morning, your evening, especially on the weekend, when I know that you probably have time with your family that you'd like to. So, but we really appreciate you taking the time and sharing your expertise in your clinic's experience with this method. And I know other parents are just so eager to be able to find a way to alleviate some of the burden and improve their child's quality of life, to make it better for everyone. So thank you again so much for your time. We really greatly appreciate it.
I thank you. I thank you because I think this is amazing for me, just to be in touch with people around the world. This kind of, I think, a miracle of these kind of technologies that make easy what I think a few years ago was impossible. So
Yeah.
what I want just to say is just a kind of positive message, because as you told before, Cobalamin C in Italy is not such a rare disease. And after my presentation in Rome 2-3 years ago, where I met Rossella Brindisi too, other colleagues, other dear friends from Ospedale Bambino Gesù, Carlo Dionisi Vici, Turin, North Italy, or even South Italy, metabolic centers are using this iPort, and the experiences they having is very, very good. I mean, it's very positive. And what we must do is, I think we must put our effort together and come out with maybe with a paper and kind of retrospective, collecting the experiences. And I recommend you as parents to make to ask to your doctors to maybe consider, and because I don't think this is, I don't want to say subcutaneous is better than I am. I'm not such a power, but I want just stimulate and to consider a different way, a different approach, which is more, I think, to take care of the other side of the family, which is the pain, the discomfort, and the quality of life. And so I'm amazed because there are few works looking at subcutaneous treatment in Cobalamin C and other diseases. And so maybe we must think to do this little great change to go deeper with this kind of way of treatment using the catheter subcutaneously. So thank you very much, and good luck for everything.
Yes, thank you so much. We really appreciate it. And Dr. Bordugo, you had mentioned sharing your slides. We're recording the presentation, but would you mind us including your slides too, or would you prefer we just email them out to those who registered?
As you prefer. Maybe you can keep the registration. I will send you even the PowerPoint slides, so you can do what you prefer.
Okay. All right. I just want to make sure you're comfortable with that. Well, thank you so much for your time. Have a wonderful evening. And for all those listening here in the US, have a good afternoon. Have a good day.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.